Hello, my name is Melissa Miller. This is my presentation for my Microbiology 24/21 class. I chose coronaviruses and COVID-19. I'll be focusing on the novel coronavirus SARS-CoV-2 and the disease it causes, COVID-19. History of coronaviruses. Discovered in 1965 by Dorothy Hammer from the University of Chicago, 229E is one of several viruses that causes the common cold. OC43, discovered in 1967, also causes the common cold and is likely transmitted by cattle in the late 18th century. SARS-CoV-1 was discovered in 2003 in Guangdong Province, China. It's responsible for the worldwide outbreak infecting 8,096 people and killing 774. NL63 was discovered in 2004 in the Netherlands, causes respiratory infections, generally mild in the upper respiratory tract and often more severe in the lower respiratory tract. HKU1 was discovered in 2005 in Hong Kong. It causes respiratory infections. MERS-CoV, discovered in 2012 in Saudi Arabia, is the deadliest known coronavirus. It infected 2,494 people and resulted in 858 deaths. SARS-CoV-2 was discovered in late 2019 in Wuhan Province, China. It's responsible for the COVID-19 pandemic and causes respiratory infections similar to pneumonia. While coronaviruses can also cause GI problems, the vast majority of symptoms are respiratory. In this picture is Dr. David Tyrrell placing cold virus into the nostril of a patient during a research trial in 1966. The characteristics of coronaviruses are that they are spherical or pleomorphic. They are enveloped in a crown or a halo of glycoproteins. They are single-stranded RNA, and they have a positive sense, which is 5 to 3 prime. So the viral RNA genome is viral mRNA and can be immediately translated by the host cell. Nucleoprotein comprised of matrix protein. Envelope bears club-shaped glycoprotein projections. On the outside of the halo are the club-shaped proteins. Coronaviruses are classified in 4 subgroups: alpha-CoV, beta-CoV, delta-CoV, and gamma-CoV. The outbreaks affecting humans have fallen into the beta-CoV genre. Discovered in late December in 2019 in Wuhan Province, China, is believed to be spilled over from horseshoe bats. They are likely contracted from infected pangolins, which are endangered and illegally trafficked in China for meat because they are a delicacy. SARS-CoV used civet cats as its host, and MERS-CoV was contracted by camels. There are 4 main structural proteins: the spike protein, the membrane protein, the envelope protein, and the nucleocapsid protein. The spike protein is referred to as an S protein. It has 2 domains, S1 and S2. The spike glycoprotein has a furin-like cleavage site, and it's important for being recognized by the pyrolysis and contributes to the zoonotic infection of the virus. The E protein is the envelope protein, and it interacts with the membrane protein in the budding compartment of the host cell. The capsid protein, or ORF9A, packages the positive strand viral RNA genome into helical ribonucleocapsid, or RNP, during virion assembly through its interactions with the viral genome and membrane protein. Nucleoprotein plays an important role in enhancing the efficiency of subgenomic viral DNA transcription as well as viral replication. The M protein, or membrane protein, holds a dormant cellular immunogenicity. There's an increasing epidemiological evidence that suggests SARS-CoV-2 has stronger transmission power than SARS-CoV, but lower pathogenicity. This is the SARS-CoV-2 spike protein. The S protein S1 attaches to the cell membrane via ACE2 receptor, which is the blue here. After internalization of the virus, the S-glycoprotein is induced by conformation changes. The S protein is then cleaved by cathepsin CTSL and unlocks the fusion peptide of S2. This activates membrane fusions within the endosomes. S2 mediates fusion of the virion and cellular membranes by acting as a class 1 viral fusion protein. High mutations occur in SARS-CoV-2 due to the error-prone RNA-dependent RNA polymerase and genome replication. These mutations are located in the S protein, RNA polymerase, RNA primase, and nucleoprotein, which are fundamental proteins for vaccine efficacy. Though there are no current available vaccines, the high-frequency single nucleotide polymorphisms, or SNP, mutations are important factors when developing vaccines for preventing infection. The pathogenesis of SARS-CoV-2 is through infectious droplets and droplet nuclei. The travel length for SARS-CoV-2 falls into the small infectious droplets category at about 4 feet for travel length. This virus can survive up to 3 days on surfaces. Infection begins with transmission of respiratory droplets to the respiratory tract or through mucous membranes. The virus then settles into the alveoli or air sacs, the tiny air sacs. The pathogenesis of SARS-CoV-2. To settle into the alveoli, the virus reproduces within the epithelial cells lining the air sacs. The initiation begins when the S protein attaches to the ACE2 receptor on the host cell. Pathogenesis of SARS-CoV-2 continued. Endocytosis occurs and uncoats within the host cell. This is followed by transcription and translation, which begin after uncoating. Mutation frequency is high due to the fact that RNA-dependent RNA polymerase of RNA viruses lack proofreading. SARS-CoV-2 RNA replication is unique in that it involves 2 RNA-dependent RNA polymerases. The first RNA polymerase is primer-dependent non-structural protein 12, or NSP12. The second RNA polymerase is NSP8 and has the primase capacity for de novo initiation RNA replication without primers. After translation and transcription, the virions are ready for packaging and exocytosis by budding. Here you can see the process of budding. This is when the host cell lyses and releases mass quantities of new viruses. SARS-CoV-2 infects both type 1 and type 2 cells. Type 1 are thin and O2 passes right through them. Type 2 cells secrete surfactant, which prevents collapse. After infection, inflammatory signals are sent and macrophages are called in. Macrophages release cytokines, which cause vasodilation. Fluid accumulates within the alveolus. This fluid dilutes the surfactant, which triggers the onset of collapse. Alveolus collapses, decreasing gas exchange and increasing the work required to breathe. After alveolar collapse, neutrophils are recruited and release reactive oxygen species to destroy infected cells. Type 1 and type 2 cells are destroyed and begin to cause acute respiratory distress syndrome, also called ARDS. The protein-rich fluid can then begin seeping into the bloodstream, causing systematic inflammatory response syndrome, also called SIRS. SIRS may lead to septic shock and organ failure, which may be fatal. The median incubation time for SARS-CoV-2 is 5.1 days. The exposure to onset of symptoms is approximately 11.5 days. The quarantine time currently is 14 days, which is an appropriate time. The symptoms include dry cough, shortness of breath, headache, gastroenteritis, pneumonia, and death in severe cases. Detection methods for SARS-CoV-2 include PCR, which is a technique for viral detection and quantification that offers advantages of high reproducibility and sensitivity. PCR measures the quantity of DNA, and reverse transcriptase PCR is used to detect RNA, which is reverse transcribed to DNA. RT-qPCR uses the same method as PCR, except the amplified DNA is fluorescently labeled, and the amount of fluorescence released during amplification is directly linked to the amount of amplified DNA. This has the advantage of in vitro detection of COVID-19. This also contains primers to differentiate between SARS-CoV and SARS-CoV-2. Immunofluorescence assays used to detect a variety of viral antigens. This method uses fluorescent label that is conjugated to the antiviral antibody, which is called direct immunofluorescence. This amount of fluorescence can be seen with the UV light. Here we see 2 chest x-rays. The specific features associated with the presence of SARS-CoV-2 include ground glass opacities in the lungs. This is visible on the x-ray due to the fluids within the alveoli, vessels, and bronchial structures. You can also see interstitial thickening and even partial lung collapse. ELISA is another detection method for SARS-CoV-2. It stands for Enzyme-Linked Immunosorbent Assay. This method can detect antibodies or antigens in a sample. If positive, an antibody is tagged and causes color change when a substrate is added. For detection of SARS-CoV-2, detection can include spike, envelope, membrane, or nucleocapsid antibodies. POC stands for point of care. Several point of care kits use PCR and can produce positive results in 5 minutes and negative results in 13. These use swabs to detect the virus. Other POC kits can use blood, serum, or plasma to detect IgM or immunoglobulin M and IgG. And COVID-19 treatments. There are no known COVID-19 treatments, but there are many possible on the horizon. These include antivirals currently circulating like remdesivir, lopinavir, and ritonavir, malaria and autoimmune drugs like chloroquine and hydroxychloroquine, and treatments that prevent the immune system damage are currently in production and are expected to be available within the next few months. These prevent cytokine storms, which can do an excessive amount of damage to one's own body. The antivirals have several mechanisms of action, including inhibiting viral application, inhibiting viral RNA synthesis and mRNA capping. They inhibit viral replication and block viral cellular entry. The anti-malaria drugs for COVID-19 include chloroquine and hydroxychloroquine. Neither is entirely known for the mechanism of action, but the belief is that they change the pH of the endosome and they supposedly prevent viral entry, transport, and post-entry events. Unfortunately, there are no current vaccines available for SARS-CoV-2, but there are vaccines in development that are or soon to be in phase 1 trials. Other investigational approaches currently being explored include interferon 1b or 1-beta, various traditional Chinese methods, and, once available, IV hyperimmune globulin from recovered persons and monoclonal antibodies that may be used in an early intervention. I used the numbers from the CDC because I was unable to locate the World Health Organization demographics. Currently, as of April 16, 2020, the worldwide total confirmed cases are over 2 million. The worldwide deaths are over 139,000, and the U.S. total confirmed cases are over 500,000, with the U.S. total deaths being over 26,000. The current R0 of SARS-CoV-2 is 2.2, but the morbidity and fatality rate is currently unknown. So the age group least affected is under the age of 18, but the most affected are between 18 years old and 64 years old. This is the current for information as of the time of this presentation. Remember, prevention starts with you. Washing your hands is truly the most preventative measure as it disrupts virus membranes. Social distancing, while difficult, prevents resources and healthcare from being exhausted, so all infected can be treated. Thank you for watching my presentation.